I am Dr. Levi from Philippines, and I'm an ENT facial plastic surgeon. And today I'm going to speak about the use of irradiated rib and dermis for rhinoplasty. Second one is I'll talk about xenografts, allografts, and autografts. And lastly, the famous now the deep plane facelift. So bear with me. It's going to be a little bit long lecture. I was given 45 minutes because Dr. Fan really loves me to talk. So bear with me. Okay? I hope everybody's not sleepy right now. Okay. Thank you very much, Dr. Fan. My first lecture is about the use of irradiated rib and dermis for rhinoplasty. And before I talk about this lecture, I would like to thank Dr. Nguyen Thanh Van, the president of the Vietnamese Society of Aesthetic Plastic Surgery, Dr. Nguyen Van Nam, the president of the MISAPS. Thank you very much for inviting me. And of course, the energetic Dr. Phan Minh Nhu, very, very famous and very energetic, didn't sleep the whole night just to organize this whole Congress for every one of us. Okay, so I hope you learn a bit, one or two from my lectures. It's not as comprehensive as the previous lecturer, Dr. Tai, but I'm doing my best to at least express this lecture to you. There are a lot of autologous grafts used for dorsal augmentation, rib cartilage. It's very used by a lot of ENT facial plastic surgeon, conical cartilage, septal cartilage harvest, human dermis, human subcutaneous fats, fascia, bone. And of course, we also use, the cosmetic surgeons use a lot of the synthetic materials like silicone, Gore-Tex, and Medfor. And now we have the donated grafts, we call as the homografts, allografts, or the isografts. The homografts are the donated rib cartilage, and could be from your own twin, that could be an isograph, or coming from the same human being, which could be homograph. And in my practice, I usually use some of these irradiated rib and dermis, which came from a company known as the LNC Bio. For my disclosure, I don't have any financial connection with this company, and I just kind of use their products in my practice. The irradiated dermis, I think, is best used for nasal bridge augmentation. And it comes in packaging like this. And megaderm, they call it megaderm for rhinoplasty, and it has different forms. It could be used for thick augmentation only. It could be used for dorsal augmentation, and it comes for pre-form or in a black form. It's different now from the previous technology, as they use alloclean technology to remove all the antigens and antibodies in the said implant. The irradiated rib, on the other hand, is best used for the nasal tip. Okay, and it comes in there are two types of irradiated rib in the market right now. That would be the human irradiated rib, and that becomes a homograph, and an equine irradiated rib, which becomes a xenograph. Advantages of the irradiated homologous grafts: it's safe, water-free, natural looking, and has almost zero complication rate. Less invasive, and according to their study, the absorption rate is around 10 to 15%. But I put a lot of question mark on this because unfortunately during our Philippine study, we weren't able to replicate this 10 to 15% absorption rate. There's zero chance of warping, as the irradiated rib has been soaked in the solution for quite some time. And this is a little bit different when you harvest your own rib cartilage, which is very prone to warping. And the idea for the whole use of homograph came from the study of Russell, wherein he used the irradiated rib for at least 1,400 patients. Imagine 1,400 patients. And in this study, he said that the irradiated homologous costal cartilage is a well-tolerated grafting material for rhinoplasty, and the complication rate is no greater than when you use your own rib cartilage. So, vis-a-vis, the homograft and the autograft have the same complication rate. The disadvantages of the IHC though, it is a single implant and cannot be reused after reopening. It's expensive and its high degree of resorption in our studies as high as 80 to 100%, and it's too short to fall for nasal definition and prone to fracture, especially with calcified implants. In our Philippine study, wherein we used for around 468 patients, starting from October 2022, there are 52 cases of significant implant resorption with the use of the irradiated dermis and the rib. And the dermal resorption are mainly due to contracted cases, infected cases, and revision cases. And that's why we finally modified this use of the irradiated dermis by adjoining the irradiated dermis with a layer of the conchal cartilage. So we harvest a layer of conchal cartilage and put it below the irradiated dermis and use it for augmentation of the nasal bridge. So we harvest it on the posterior approach. We harvest a big portion, around 2 centimeters. And then I use my sheet grid to measure accurately around 1 centimeter will be adequate. And then use this kind of instrument, it's called a moisturizer, to flatten, or I call cattle crusher, to flatten out the curvature of the conchal cartilage. And then I cut around 1 centimeter of this conchal cartilage, and then suture it with a PDS 50 at the bottom portion of the irradiated dermis to prevent the high degree of resorption. The idea behind this is that because the ear cartilage is covered by a percondrium and stimulates neovascularization as fast as 2 hours after augmentation, as compared as if you use just the irradiated dermis, neovascularization occurs after 2 weeks. Okay, so this is how it looks like after. And then suture it. This is a 2-layer ear cartilage beneath the irradiated dermis. Then this is the irradiated dermis beside the irradiated rib. There's as I said, there are 2 types of the irradiated rib, and I prefer the equine type. The equine type is harvested from the scapular cartilage of young horses as young as 36 months. And after removal of the surrounding tissues, the cartilage was carved into standardized size, 4 cm in length, around 0.7 to 0.9 in width, and 0.25 to 0.49 in thickness. The material was processed with delipidation, decellularization, and virus inactivation. Sterilization was performed using gamma irradiation. Now, according to the study by Dr. Yung John Chang, the efficacy and safety of the equine cartilage for rhinoplasty is a multi-center double-blind approach study, wherein in this study, it was shown that the processed equine cartilage can be effectively used and safely as a xenograft material for rhinoplasty. I was very afraid to use xenograft in my rhinoplasty at first, but as I researched further, there are several advantages of the xenograft. It's relatively cheaper and a longer size. Then there's only 10% absorption rate in my 18-month study, and it's a stronger cartilage that is prone to fracture. That's not prone to fracture. There's no calcifications because they were harvested from young horses, and it's a well-tolerated implant with 0 infections in more than 400 cases that we did. The autoimmune reaction is also 0. after 18 months. It's a forgiving graft, even to the most demanding nasal tip definition. There's no danger of skin perforation because of immediate angiogenesis after augmentation. There's also longer shelf life of around 3 years. Now, the disadvantage is that there's a stigma, I know, in the use of xenograft. Not all of us are open for the use of xenograft. As I said before, I was also afraid to use xenograft in my augmentation trying to steam. But as I researched further, I have known that all the like Restylane or thermal fillers, came originally from the rooster's womb. So it's also a form of xenograft that I know is widely commonly used. So I became braver and used it now for my augmentation pregnancy. And of course, who would forget botulinum toxin, which is a toxin which is widely used in our practice. Now, the technique involves like this. So this is a published paper in our country and also submitted in the Aesthetic Plastic Surgery Journal. Okay, so the nasal septum, the mucosa, is released 1 centimeter on its dorsal strut, wherein you could anchor now the irradiated rib on this side. Now, the irradiated dermis with some form, with one layer of the ear cartilage is placed on the nasal bridge. And on the nasal tip, the irradiated rib is sandwiched with a layer of ear cartilage and placed on the dorsal strut of the nasal septum. And if the irradiated rib is too strong, you can cut it and put a layer on it as an only graft. Okay, so this is how it performs. You could curve the irradiated dermis, the block time, using your Volvier rotating burr. I usually use the one that have been previously used for mastoid surgery. So as not to consume a lot of money in buying the new burrs. Okay, and then the irradiated rib by halving half into 0.5 centimeter, 0.5 millimeter on both sides, and then conjoin them using the PDS 50. So this is how it looks like. So it's so strong, so high, right? But this too high, too strong, would project a very unnatural or artificial looking on the nasal tip. That's why I cut it a bit. I cut the extra portion using my blade 11. Okay. Now that extra portion, don't throw it away, and you could use it now as your polygraph. Okay, so you could suture it using PDS 50. Now, with that in mind, you have a very strong strut graft, also a very strong poly graft, and a very strong bridge orientation, which has less prone to resorption. Okay, so this is the innovation that we had and was published already in our country. So. Okay, so this is a summary of what we did. So the ear cartilage was halved 1 centimeter and placed underneath the irradiated dermis. And then some of the patients that we did, and cover it using a Denver splint. I think it's better to cover it with the Denver splint. So these are the pre-op pictures, and then the post-op pictures. So it's a little bit more superior, as it's more natural looking. as compared that if you use just an alloplastic, like silicone or some just Cortex. Okay, so I made a palette for my patients. So what do they like? So if they like a natural looking nose, a type nose, hybrid nose, soft masculine, strong masculine. So it's your choice. It's like a palette that I just made for promotional purposes in my clinic. Okay, so these are some of the patients that I perform. So correction of the butterfly nostrils. It's very effective. Also for the correction of the deviated nose, for bulbous nose, barbershop type. So like this, the bulbous nose, you can correct it very nicely with the use of the irrigated lip. Also for short nose, short and small nose. Imagine if you're having a short and small nose, if you harvest the septal cartilage, it's just very small. Some of the patients also before the surgery and after the surgery. So before, after a month. And also the irrigated prevendermis is not complication free. There are also complications by the irrigated dermis, and also the rib. It's mostly caused by the lint and some debris in your operating field. Okay, so please be careful with the lint. The lint comes from the linen that you use for recovery. So if there's some linen that goes inside or is attached to your irritated dermis, it's very prone to swelling and maybe some the implant will be resorbed. So it's best if you see something like this to irrigate it using gentamicin solution. So I use this one, the speculum. The suction tip, and insert it directly to the area on the nasal bridge over here and irrigate it with the gentamicin solution. Okay, thank you very much. I think that will be my first lecture, and I still have 2 more lectures and still have 40 minutes, 30 minutes. Okay, thank you. Thank you very much. Okay, so this is my second lecture. Okay, so there will be xenografts, autographs, and alloplasts for augmentation rhinoplasty. Okay, I am again, I'm Dr. Levi. Now I'm also the medical director of Dr. Shima Aesthetic Center, and now the chairman of the Philippine Cosmetic Surgery Board. And these are some of my qualifications. Alloplasts are very common to you. I know a lot of doctors here use alloplasts for augmentation rhinoplasty. So alloplast, the most common is the silicone implant, and the other very common alloplast would be the EPTFE or the Vortex or our diamond sponsor right there, Surgiform, is one of the EPTFE. Okay? It can be divided into celastic or porous. Okay. Celastic will be silicone, SS, so easy to remember. And the Vortex is the porous one. The silicone implant can come into 2 forms or 3 forms. It could be the L type, the bird type, or the I type. Okay? And okay, so silicone is easy, simple, safe, and economical. So I have watched video about SR rhinoplasty, and it's the most common alloplast material. I know a lot of doctors here are using it, and it's flexible and can easily be contoured with the patient's facial condition and heals by encapsulation. Still a foreign body though, thereby. Any foreign body, there's already a study about this, any foreign body inserted in your body has an 80% chance of infection unless properly sterilize and practice good surgical techniques. Okay, please remember that. And calcifications later on the implant develop with the implant. Okay, and problems with the silicone implant is that going like this, okay, rejection, especially if they use the L type of an implant. Okay? So I know you have seen horror stories about this. And that's why I prefer to use the I type of the silicone implant and then suture it along your upper lateral cartilage using PDS 50. And then you could use your ear cartilage as a buffer and protect it from moving as a backstop graft or a shield graft to prevent it from moving. Okay? I have nothing against the silicone, but I think it's better to use the I type of an implant because the L type of an implant prevents the movement of the nose, wherein the nose is a dynamic structure and has articulations with the upper lateral cartilage, with the lower lateral cartilage, and the lower lateral cartilage with the septal cartilage, which are all part of your major deep support mechanism. Okay? So I also don't like the technique of using a one-side incision because it is called as a heavy transfixion incision, wherein it's also promoted as a 15-minute rhinoplasty, wherein one side of the nostril was incised and an implant is pushed on it, the silicone implant. Usually, the implant will be protrude and move. This is because it will follow the dominant hand of the surgeon or the area of weakness wherein the implant was inserted. Okay? So, this is what I'm saying. The nose is a dynamic structure with articulations with the lower lateral cartilage and the nasal hole. It's all confirmed by opening the cadaver. Now, so you can see this is one of my patients with a silicone implant. Then was revised with use of a vortex and and some septal cartilage on the nasal tip. So when planning for the nasal tip, it's best to use the Gunter's chart. You could bang the septal cartilage, harvest it, and then retain 1 centimeter of the superior and 1 centimeter of the anterior strut. And then plan it if you're doing just an SEG, be an only graft or a shield graft, or you could plan it with the use of the cephalic trimming or an alar trimming. It is best to use the proper instruments when doing rhinoplasty, not just a scissor and some retractor. It is best to use that you have the mallet, the curved osteotomes, the Rubin osteotomes, and the color crushers. You all need these to have a proper and ideal result with your patients. Okay, so this is one of the patients who had a previous silicone nose lift and then revised using vortex with some with septal cartilage, SEG. So after a month, so it becomes more natural looking. Okay, so the results are more natural looking. So this one came to my clinic with an infected silicone implant. So I revised it with the use of the dermis. So the thickest part of the dermis is harvested on the sacral area. It's around 4 millimeter in thickness. So you could harvest it and then place it on the nasal bridge. And then also, as my previous lecture, I kind of use nowadays the irrigated dermis for infected cases. Now, the long-term effects of silicone implant is that it develops calcifications. So as time goes by, and these calcifications, when they feel the nose bridge, is very rough. Okay, so I think that is the only disadvantage of the silicone, aside from the infection, is that it also develops calcifications as time goes by, and thereby the nose becomes artificial looking, or everybody notices that someone had a nose augmentation. Okay, so the video presentation is not needed, as everybody here knows how to do the silicone rhinoplasty. Okay, now I'll discuss about EPTFE. EPTFE, or the vortex implant, is not a perfect implant. Also, there are a lot of complications with the EPTFE. One could be asymmetric swelling the square nose syndrome, infection, malposition. Okay, and when there's vortex infection, the presentation is very severe. It's kind of like a balloon, okay, that makes the nose so big. So the problem here is that if the patient nowadays will go to social media and post that you perform a surgery on them and present their nose in the social media with like an elephant nose, right? So it's very dangerous in our practice. So the infection with the vortex could come like this. It could be like a pimple on the upper portion, or can protrude and cause perforation on the skin. So it's really dangerous if someone posts like this in the social media, okay, and then tag you along. Very dangerous. So we have also a lot of flap techniques. This one we published together with my mentor, Dr. Dong Hak-jung from Korea. It's the subnasal flap for correction of the columellar deformity. So columellar defects are composite graft. We produce composite graft, nasolabial flap, forehead flap, the pressurized oris flap, and the transverse fork flap. And on the other hand, we could also use the subnasal flap, which has greater chance of flap survival and has minimal scarring. Okay, in this paper that was presented and was published in the Plastic Reconstructive Surgery Journal, is best used for columellar defects, and the incision starts in the nasal region, extending into the nasal cavity. Okay, so you could just Google it and learn more about this paper. So for patients, if you have some patients with columellar defects, this will be very helpful. Okay, for correction of deviated columella, also very helpful. Like this. Cleft lip, cleft nose, okay. In this, I borrowed this picture. This is my patient. So just do a transposition flap or the septal translocation flap plus the subnasal flap. So emerging problems nowadays is this necrosis. Okay, with the use of the dermal fillers. There are a lot of instances of the tip necrosis, the nostril necrosis, and of course, this is very dangerous. Okay. As I said, somebody posting this in social media and then tagging your name along could destroy your practice. And okay, this is my mentor. Okay, we use the midline paramedial flap for this. You could correct it. But our country is just a little bit more conservative also. They don't like too much of scarring and flaps. So you could use, if they don't like things like that, you could use the composite grafts. The perichondrium is an irregular connective tissue and has two layers. The outer fibrous layer and the inner chondrogenic layer. The outer fibrous layer contains the fibroblasts, which produce the collagenous fibers. So that's why the perichondrium is very important when doing a reconstructive surgery. In the healing process, it is divided into four: adherence, intubation, revascularization, and remodeling. So you need revascularization in order for the graft to heal and to be alive. Okay? And this is a nasal reconstruction in the diabetic patient. Okay, I am a co-author of this paper, and it's used best for contracted doses, absent columella and artificial columella. Okay. So you harvest the ear, posterior approach, and then posterior or anterior approaches could be, and then you could use the ear cartilage and sandwich it with your irrigated rib. Okay? Now you have a strong graft, the irrigated rib. Now the problem is how you will you reconstruct the columella because the skin is also a problem. The mucosa is also a problem. So you could use what I discussed a while back, the subnasal flap, to bring some skin over it. So as I said, the gold standard is the island forehead flap, but not all patients want a scar over there. Okay, so this is your alternative if the patient doesn't want the island forehead flap. So you could use the subnasal flap now to cover your irritated rib plus the ear cartilage that goes along with it. So, and then you could use vasodilators afterwards. So you see this, 3rd day, 7th day, I am a failure. Okay? On 10th day, I am having some signs of life. On the 15th day, becoming better. On the 20th day, looks much better. And 32nd day, I think the flap, either graft plus the subnasal flap is alive. Okay, so this and he's very happy. You can see his face on the 40th day post-surgery. So reconstruction of the retracted columella in diabetic patients requires thoughtful layering of structural, soft tissue, and wound healing strategies. This case demonstrates that a combination of subnasal flap, the skin perichondrial graft, a cellular dermis, and irritated rib cartilage, supported by holistic adjunctive care, can lead to excellent outcomes. This approach may serve as a model for similar high-risk reconstructive challenges. Okay, so I think that would be my second lecture. And my third lecture, so I think I still have time. A lot of doctors here are performing deep plane facelift, but I know a lot of ENT facial plastic surgeons and plastic surgeons as well can perform deep plane facelift. Okay. The deep plane facelift works by repositioning deeper facial structures beneath the isthmus. They are addressing sagging in the midface, jawline, nasolabial lines without the pulled loop. What is the pulled loop? It's what we call as the wind-blown loop. So it's a surprise loop. So nobody wants that artificial look. Everybody wants a natural-looking face look. Okay? Now it's becoming very popular because of the Kardashians. The Kardashians, okay? After Kris Jenner has this deep plane facelift, everybody now wants to have deep plane facelift. Okay? So it's becoming popular in our country. I don't know about here or in other countries, but I know in the United States and the Philippines, deep plane facelift is becoming very popular. And the definition, a surgical technique that repositions both the skin and deeper tissues as a single composite flap. Okay, it was invented by Dr. Sam Hamra in 1990s and later refined by surgeons like Dr. Andrew Giacono and Dr. Brian Mendelson. Target areas will be the mid-face sagging, nasolabial folds, jawline laxity, and the neck. How it works? Incision is around the airline and air contours. Okay, you could modify it through a vertical line incision or just a small scar incision. Okay, so this is how we do it. So if the patient wants deep plane facelift, it could begin on the temple area, the line, and then extending on the occipital region. Okay, so this is the marking of incisions. The key here is the release of retaining ligaments. Okay. It is not your duty to identify all the facial nerves in performing deep plane facelift. Please remember that because it would take a lot of time to identify all the facial nerves. Your job here is to release the key retaining ligaments of the face. And there are only two major true ligaments of the face that must be released. Okay, so first would be the zygomatic ligament, and the second would be the mandibular ligament. These are two strong ligaments that have to be released by cautery or your sharp-edged scissors because these other ligaments, like the mesenteric ligaments and the orbital retaining ligament, can be released using your manual palpation, or the what you call as manual exploration of the face. So you can just remove it using your index finger. Okay. The orbital retaining ligament is around this area, and then so the technique there is you release the orbicularis oculi, which is a continuation of your isthmus. Okay. So remember, when you dissect deep plane, you go deep plane on the layer of the orbicularis oculi muscle and elevate the orbicularis oculi muscle and release the two ligaments, or orbital retaining ligament and the zygomatic ligament. Okay, so this is the orbital retaining ligament. So after elevating the orbicularis oculi muscle, so you could just cauterize it and then cut it. Okay, this would be the zygomatic ligament right there. Okay, so you could just also cauterize and cut it, okay, after identifying it. Okay. So, as long as you release the retaining ligaments, you will have a very successful deep plane facelift surgery. Okay, so after releasing that, you could now insert your finger and explore that area along the malar bone. Okay, along the malar bone, there are no nerves to avoid, so there's no danger of injury to your facial nerves. Okay, now will be the difficult layer. Deep plane facelift below the arch of the zygomatic bone. Okay, as you dissect along the deeper layers, the spaghettis, we call these the spaghettis. The spaghettis are now beginning to appear. Okay, what are these spaghettis? The zygomatic branch of the facial nerve, the buccal branch of the facial nerve, the marginal mandibular branch, and of course the cervical branch. Nobody wants to hurt these branches because cutting the spaghettis means the doctor going to the court and answering for his injuries. Okay? So nobody wants that. So when doing the deeper layers, you have to be a little bit careful. Okay? Dissecting properly, sub-isthmus along the parotido-mesenteric fascia, elevating the parotido-mesenteric fascia. Okay? So you could use blade 15 in elevating the parotido-mesenteric fascia all the way to the platysma. Okay? So sub-parotido-mesenteric fascia continues to the platysma, then sub-platysmal level. Okay, so this would be how it looks like after elevating the platysma. Now you could identify all the structures. That would be your submandibular gland. That would be your sternocleidomastoid muscle over there. That would be your parotid gland. And extended, that would be the deep layer of the parotid gland. Okay, and that would be the masseter over there. This would be your buccal fan. Okay, so you could see now the retaining ligaments of the masseter are all released. Zygomatic ligament is also released. This is what you call as a total composite flap that you could now pull as a one thing. Okay, so you are now correcting all the layers, all the lines of aging. Okay, and then you could release the isthmus. So it's like a page of a book. If you could flap it like a page of a book, you are successful in doing a deep plane facelift. Okay, and then cut the extra layer. and then suture it using nylon 50. Okay, I have a better video. I still have a bit of time. Okay. And deep plate facelift, this is not the purpose of the surgeon to identify all the branches of the facial nerve. That's what I said a while back. Just identify them as spaghettis. Okay? So don't identify them. Your job is to avoid them. Just avoid them. Okay? How do you avoid them? Have a GPS. Okay? What do I mean by GPS? Have a map, a workable map on the face, because every human being is the same. Okay? It's not like a Filipino or a Thai or a Vietnamese have different facial nerves. We all have the same facial nerves, and their locations are very predictable. Okay? Very, very predictable. Okay, now, the retaining ligaments, as I said, are two most important: release the zygomatic and the mandibular, and then just use your finger to release the mesenteric ligaments. Okay? And this one is one modification. It's a short scar technique. Okay? I kind of use this dissector to release just the skin. Okay? Now, after releasing the skin and reaching the orbicularis oculi muscle, which is already part of your isthmus, I would now identify my orbital retaining ligament. Okay. Here, you could just cauterize the orbital retaining ligament. Okay. So because you want to elevate this as a one composite flap. Okay. Now this one would be the release of the zygomatic ligament here. And then here, you see I am using a plate 15 to release the parieto-mesenteric fascia. So the parieto-mesenteric fascia is a fascia that covers the parotid gland that is continuous with your masseter muscle. Okay? So avoid reaching the arch of the zygoma, because along the arch of the zygoma would be the branch of the zygomatic nerve, which they are you're in danger of hurting them. Okay, and then release it using the elevator. And now, you see this, I am cauterizing and releasing. You could see some contracture, okay, of the muscle, but I am now cutting the mesenteric ligaments. You could see some contracture, don't be afraid about that. If you're sure, that's good. Okay, so I think, okay, I am down to my last minute. So that would be it. And then suture it. And like this afterwards. Okay, for my final slide, see this. If you were able to do this and elevate everything, then you perform a good deep plate facelift surgery. So these are just some of the patients that I did. And thank you very much for your kind attention.
Thank you, Dr. Levi.